Hi everyone. Today we'll be talking about the PACES abdomen short case. So once again, we'll begin with an overview of the types of cases you see in the abdomen short case. At the outset, it's important to try to distinguish whether this is a hepatology, renal or hematology abdomen short case. And to some extent, this is really the crux of the abdomen exam. And being able to distinguish between the three systems early on will help you be able to home in terms of specific things that you want to examine for, and in terms of helping you think of appropriate differentials and discussion-related questions. So let's break it down. For the hepatology case, in majority of the instances, it is someone with chronic liver disease with or without portal hypertension. So portal hypertension is usually evidenced by the presence of ascites or splenomegaly. So in terms of holding a discussion or summary statement, it is always helpful at the outset to say this is a patient with chronic liver disease complicated by portal hypertension if it is present. And this very nicely helps you summarize the case. The presence of hepatomegaly in an isolated fashion or in the context of chronic liver disease can happen too. If it's hepatomegaly alone, then it's your approach to a lone hepatomegaly, although that is not extremely common. In the context of hepatomegaly in chronic liver disease, we'll discuss about it later on. Ascites alone as a standalone sign also is not very common in the context of in the context of chronic liver disease. Once again, this is tied in with portal hypertension. And liver transplant in the local context of PACES is also not that common. For renal cases, most commonly would be ballotable kidneys, usually secondary to autosomal dominant polycystic kidney disease, or it could be a renal allograft, or sometimes a combination of the two. And for hematology, there are two broad groups. First are the hematological malignancies, hematological malignancies instead of disorders, and chronic hemolytic anemias. So let's talk about an overall approach. Like we mentioned, the first is determining the system. And there are some things that you can do on general inspection. If you notice jaundice, if you notice pedal edema, it could be a liver case, although pedal edema can be due to fluid overload and a renal abdomen case. For renal cases, you can hunt for excess sites, look for catheter scars, parathyroidectomy scars, deltoid implant scars, which are hard to find. And in hematology cases, you can look for catheters, or for chronic hemolytic anemia, there can be extramedullary features, there can be bony features of extramedullary hematopoiesis, such as frontal bossing and maxillary hyperplasia. Next would be to determine the main abdominal finding that will anchor your differential consideration. So it can be a single enlarged organ, so like a liver, a spleen, or a kidney. Or it can be two enlarged organs. So in this case, it's usually a hepatosplenomegaly versus a bilateral ballotable kidneys. And sometimes, especially in patients who are larger inhibitors, it can be quite challenging to differentiate the two, even if you attempt to systematically go down the distinguishing factor. So first and foremost, it's important to be able to know how to distinguish based on whether it's dull or resonant percussion, whether you can get above the mass, whether it's ballotable or not. And it could be a transplanted organ, and ascites, as mentioned, could be the other, although not so common, anchoring main abdominal finding. So this is a quick revision about scars. Scars are important, and it is important to be able to contextualize your scars based on the system and the likely underlying condition. So in liver transplants, you can see a Mercedes-Benz scar. You can see a Cocker scar and cholecystectomy, and you might want to think of chronic hemolytic anemias because they are at risk for gallstone disease and may necessitate cholecystectomy. Nephrectomy scars are also important. Transplant scars for kidney, and if there are left-sided scars, you might want to think of splenectomy in the context once again of chronic hemolytic anemias. So we'll talk about the hepatology cases. So first we start with chronic liver disease, which would be the majority of the liver cases. So the signs are, as mentioned, and this are usually due to manifestations of hyperestrogenemia. In terms of staging the severity, we are all familiar with the Child-Pugh scoring, so it's good to have a quick revision before the exam. And these are the associated clinical features of the respective parameters that are being evaluated. In terms of etiology, I'm sure most of you have your own way of remembering the etiologies, but it's important to not miss out common ones such as alcoholic liver disease, viral hepatitis, and NASH. And once you give those as your likely etiological differentials, then you can talk about some of the less common ones. Of course, unless you have good reason to think of the less common ones above the more common three that have been mentioned. So then we talked about portal hypertension. So it's chronic liver disease with or without portal hypertension. As mentioned, splenomegaly and ascites would be cardinal features of portal hypertension. It's important to know important differentials for ascites with abdominal pain, namely SBP, portal vein thrombosis, and HCC rupture. This can come out in your questioning. Ascites evaluation is first and foremost predicated upon the serum ascites albumin gradient, where high sec suggests portal hypertension or transudative equivalent, although we don't use the terms transudative and exudative when it comes to ascites, and low sec would be your non-portal hypertension causes. In terms of causes of portal hypertension, you can think of it in terms of pre-sinusoidal, sinusoidal, and post-sinusoidal, with the causes elucidated as below. So hepatomegaly in the context of chronic liver disease can be due to etiological reasons or complications such as HCC. The etiologies of chronic liver disease that can manifest with associated hepatomegaly include alcoholic liver disease, non-alcoholic fatty liver disease, hemochromatosis, and PBC. Other causes of hepatomegaly that you would think of apart from chronic liver disease would be infections such as viral infections, acute viral hepatitis sometimes, malignancies, primary, secondary hematological, infiltrative disorders, and so on. So when it comes to the presentation, it is important to be able to summarize well, to be able to come up with a good summary statement that lists the key essential features. So chronic liver disease would be a keyword. Portal hypertension, if you want to include the concept of decompensation, especially in a patient who's overtly jaundiced, overtly acidic, with an element of, let's say, a flap, that could be helpful as well. So then you go on to say it's evidenced by stigmata of chronic liver disease. You list the features with associated complications of portal hypertension. Then you state the significant negatives in terms of hepatomegaly and the absence of hepatomegaly and absence of ballotable kidneys. Then severity, and then the etiology. So this is a very busy slide about investigations. It is always important to contextualize your investigations based on the stem that is given. So let's say it says a patient comes in with abdo pain and you notice the patient has ascites. Then you would want to contextualize your differentials as such. Depending on what the main abdominal finding is also, that could prioritize your differential. So for example, if you know a mass, you may want to characterize the mass with imaging studies. If your main finding is that of ascites, you may want to confirm it with imaging, subsequently perform a diagnostic paracentesis with the attendant relevant investigations. Then for patients with chronic liver disease, you want to work up the etiology. So this lists the relevant investigations with consideration of liver biopsy if, let's say, a cause cannot be established. You want to evaluate the severity of the liver disease based on Child-Pugh, and finally evaluate for other complications such as malignancy and hepatorenal syndrome. Management-wise, so this is a management overview where it's multidisciplinary, involving the hepatologist, allied health staff, anchored patient education with preventive measures, treatment of underlying disease, relevant screening measures, and treatment of complications as described below. So we move on to the renal case. So for renal, the commonest would be that of your autosomal dominant polycystic kidney disease manifesting with ballotable kidneys. Of note, you can get bilateral ballotable kidneys. You can get predominantly one side that's bigger than the other. You can get some of APKD with previous nephrectomy scar because of a complication. You can get your ADPKD with a transplant as well, with perhaps a nephrectomy as well. So it is important to be able to systematically distill and differentiate and come up with a system in terms of asking yourself, okay, this is a patient with, let's say, multiple scars. You ballot the presence of a kidney. You notice let's say, a possible allograft. How do you systematically put things together in your head, and how do you systematically present this to the examiner? So this is something to bear in mind and to think through yourself. In the renal case, oftentimes you encounter patients with end-stage kidney disease, so it's important to talk about renal replacement therapy, both past and present. So for renal replacement therapy, you can get AVFs and AVGs. It is important to hunt for the AVF and the AVG because in some patients, it can be cited at inconspicuous places such as the thigh. So we have seen patients with AVS, AVGs in the thigh, and if you do not adequately expose the patient or offer to expose the patient, you may miss these. Hemodialysis catheters that can be tunneled, non-tunneled, and peritoneal dialysis catheters as well. It is good to avoid eponymous terms such as Tankor catheters or let's say a temporary catheter, and use more appropriate terms like whether it's a peritoneal dialysis or whether it's tunneled, non-tunneled hemodialysis catheters. Don't forget that transplant is also a form of renal replacement therapy. A patient could have previously failed transplant and is currently on an alternative form of renal replacement therapy, such as through hemodialysis or peritoneal dialysis. So in your mind, it is important to map out what is in the past, what is in the present, what is the patient currently dependent on. It is important to remember that patients don't suddenly become RRT independent out of the blue. There must be something keeping them going. So in a patient with, let's say, a non-functioning AVF at present, you need to ask yourself, have they received a new transplant? Are they receiving renal replacement therapy from elsewhere at this point? Complications-wise, anemia. Bone health, there's not much you can go by except for the presence of a parathyroidectomy scar, deltoid implantation scars that may suggest tertiary hyperparathyroidism. Fluid status is important, and evidence of uremia. Clinically, you can assess this with a flat pericardial rub or evidence of coagulopathy. These are the commonest causes of ESRF. I put APKD at the front because it's something where you can pick up signs. For the others, in terms of DM, hypertension, GN, it may be less apparent. DM, you can look for finger prick marks. Hypertension, you can offer to check the blood pressure of the patient. And in terms of transplants, you need to answer the additional questions of whether the graft is functioning and whether there are complications of the transplant and immunosuppression. So for ballotable kidneys, these are the causes of unilateral and bilateral ballotable kidneys. And there are also other associated conditions that can cause multiple renal neoplasm. Of note, tuberous sclerosis causes angiomyolipomatosis, and von Hippel-Lindau causes clear cell RCCs that can sometimes be bilateral as well. So this set of slides is the content for ADPKD, where you probably have to commit to memory. It's autosomal dominant. PKD1 occurs due to mutation in chromosome 16 and PKD2 on chromosome 4. It is important to know the complications. So I think of it in terms of, so general ones would be hypertension, polycythemia. In terms of the extrarenal, I think of it in terms of A, B, and C. A for abdomen, so you can diverticular disease, hernias. B for brain, so berry aneurysms that can cause cranial nerve deficits, hemiparesis, so you can screen the cranial nerves, and for pronator drift. And C for cardiac, that can cause multiple valve pathology such as MVP, MRAR, and cysts involving other areas. For renal complications, this can be due to infections, bleeding, and malignant transformation of a cyst. Diagnosis-wise, it's predicated upon family history as well as supportive sonographic findings with screening indications as below and the relevant Ravine's diagnostic criteria. CNS screening is indicated for patients with family history of ICH or a known aneurysm. And in these patients, rescreening is conducted every 5 years if at the outset it's normal. Indications of nephrectomy is important. This includes complications such as bleeding or infection, or in a patient receiving a transplant, sometimes there may be space constraints because the enlarged kidney is too big. So sometimes it has to be removed to make space for the transplanted kidney. So we talk about the renal allograft. The questions to answer are largely similar. So we talk about etiology, previous RRT, but in addition, we need to talk about graft function, immunosuppression, complications of ESRF as mentioned. These are the differentials for an RIF mass. You may have to talk about it in the patient who has a renal allograft. And immunosuppression-wise, there are steroids, calcineurin inhibitors, and these are the relevant complications. Of notes for cyclosporine, you can look at gingival hypertrophy, hypertrichosis, and tacrolimus. They can get tremors. It's also important to offer a skin surveillance exam to look for any skin lesions because these patients are at risk for dermatological malignancies. And transplant complications can be classified as acute or chronic. Acute can be due to surgical complications, rejection, and chronic you can get immunosuppression-related complications, delayed rejection, and disease recurrence. So for the hematology group, as mentioned, there are two main groups. The first is your Myelo lymphoproliferative disorders, and the second group is the chronic hemolytic anemias. I won't go through too much details, but in terms of clinically what's relevant, usually these are patients with massive hepatosplenomegaly. You want to hunt for the presence of lymphadenopathy. If present, may cue you into more likely lymphoproliferative versus myeloproliferative disorders. Look for BMA scars as well. These are the main myeloproliferative disorders. PRV, which normally causes polycythemia instead of anemia, so they will be redder instead of paler. ET, CML, and MF. So in terms of investigations, this is an overview of investigations, starting from full blood count, looking for abnormalities in the relevant cell lines, peripheral blood film to characterize the different cell types. And there are certain specific things like blast that you want to look out for, or leukoerythroblastic picture that can be seen in myelofibrosis. Imaging is important, especially if there is organomegaly and lymphadenopathy. And you want to do bone marrow studies looking for cytology, histology, immunohistochemistry, and cytogenetics to characterize the type of myelolymphoproliferative disorder. Specific tests include JAK2 for ET and PRV, as well as Philadelphia chromosome for CML. Treatment-wise, this is just a very broad overview. You probably have to get a tutorial from the hematologists for more insights with regard to treatment. So the next group will be the chronic hemolytic anemias. In the context of our local population, often would be a beta tau major patient. In the Western population, sometimes you get hereditary spherocytosis. But it's good always at the outset to say that to offer chronic hemolytic anemia before you talk about thalassemia specifically. So in terms of the physical examination, it's important to comment on the presence or absence of bony features of extramedullary hematopoiesis. Abdominal scars are important. Specifically, may suggest cholecystectomy on the right and splenectomy on the left. And it's also important to evaluate for complications of iron overload, such as hepatomegaly, fluid overload, heart failure, and diabetic prick marks. So investigations-wise, full blood count for anemia, hemolysis, investigations, HB electrophoresis to differentiate the types of thalassemia, and genotyping and mutation analysis. Treatment-wise is generally, well, first and foremost, supportive with transfusions, appropriate replacement, iron chelation therapy, especially in patients who undergo long-term blood transfusion. Splenectomy, this is to reduce the splenic sequestration and RBC consumption. And it's important to remember your types of encapsulated bacteria and the vaccination that will need to be redone for these patients. Bone marrow transplant in serious cases, but oftentimes this will normally happen in the younger patients, pediatric population, and treatment of complications, and finally genetic counseling. So we've come to the end of today's talk about the PACES abdomen short case. I think the key really is at the outset, being able to distinguish the different types of systems, whether it's liver, kidney, or hematology. It is important also in terms of your presentation set piece to be able to contextualize to the different types of cases. So this is a little bit different from cardio respi, where it's a little bit more set piece in those instances. But in the case of the abdomen short case, number one, the way you present is quite different because the pathology, the complications are different for each systems. What you might offer as your wish list may also differ, because you may want to offer certain specific things in certain conditions based on the types of system. So I hope that you found this helpful, and all the best.